Hello and welcome everyone, and thank you for joining us at this webinar this evening, where we're going to present the consensus pathway for uncontrolled asthma. This webinar has been brought to you by the Accelerated Access Collaborative, which I will come to in a moment, and really we've been helped along by Kagora, which have helped us produce the material for this evening. So my mouse has just got stuck. So I tested this all just before we started and it all worked really well. So just give me a moment because I seem to be stuck. While we're trying to get this to work, I will perhaps just talk to you very quickly about the Accelerated Access Collaborative. So this is the third webinar we put together, and the aim of the Accelerated Access Collaborative was to increase the uptake of biologics for people that have severe asthma. And we've worked with Oxford AHSN and also AHSN across the country, and I am going to have to ask my technical team to help me out. There we go, brilliant. So as if by magic, if you're having technical difficulties yourself, please email that email address up there. I should have done that myself. If you have any questions for the speakers, there's a Q&A box, please pop it in there. We also have the chat open. That's just for sort of if you want to chat about something, but really for questions, just pop it in the Q&A, and we put plenty of time aside at the end to go through them. So the next slide, please, Hannah. So really, like I said to you, the overarching arm of this whole program was to increase the uptake, or I said the appropriate uptake of biologics in severe asthma. And so through a period of work, we've come out with what we call this consensus pathway, which is meant to be a pragmatic guide, and really is there to sort of inform and raise awareness of what we think is consensus best practice. And we're hoping that it'll start conversations locally and within your region about how we can redefine asthma pathways and how we can improve asthma outcomes. Next slide, please, Hannah. So how did we come about this pathway? Well, we started working on it last year in the summer. So we had our first meeting in June, where we set up a sort of a working group, and then we divided into 3 subgroups that are led by the speakers in the webinar this evening. And the subgroup sort of concentrated on sort of the patient pathway within primary care, secondary care, and then severe asthma centers. We had lots and lots of sort of further meetings with small group and large groups. And then we had a draft of the pathway that was produced. It went out for consultation earlier this year, and hopefully many of you had a chance to look at it and to comment. And from all the feedback we've had, we've managed to now come out with what we believe is the best consensus. We've also worked with partners down below, as you can see, so the British Thoracic Society, Primary Care Society, ARNS, Asthma and Lung UK. And really this whole thing is being supported by the Oxford AHSN and led by the Accelerated Access Collaborative. So, and the final thing to say is that the main output of this pathway is going to come out as an interactive PDF, and that'll come out at the sometime in April, and there'll be links at the end of the webinar to show you more about where you can go to get that information. So what are we going to cover this evening? Well, we're going to have an introduction by Professor Andrew Menzies-Gow, who works at the Brompton, and he's going to sort of give you a bit of an introduction on where we are at the moment. And then I want to present our 3 fantastic leads. So we've got Dr. Steve Holmes, Deepak Subramanian, and David Jackson, and they will go through each of the parts of the pathway. And really, I can't thank them enough for bringing all of this together. And then at the end, we'll have plenty of time for a panel discussion. I've just realized I didn't introduce myself. So my name is Natasha. I'm a consultant in Southampton, and I've worked with colleagues within the AAC, the people on this slide and several other people to sort of bring together what we hope is going to be a path that will help improve the management of patients with uncontrolled asthma. I'm going to hand over to Professor Andrew Menzies-Gow now. Andy.
Thanks, Natasha. A pleasure to be here tonight with all of you. And before I start, a massive thank you to the whole AAC team. So Natasha and Gronya have been our 2 clinical champions. They've done an outstanding job, and everyone's worked really hard on this because we're all really passionate about improving asthma care. So just to set the scene and put this in context, now clearly we all know asthma is the most common respiratory condition in the world, and in the UK with up to 5.4 million people suffering with asthma. And we are focusing on the severe end of the pathway here. So that's about 3.5 to 5% of the people we look after. But this is a whole pathway solution. And I think as we move towards integrated care systems, recognizing the whole patient journey, people aren't magically made to have severe asthma. They start and they go along that pathway. And certainly what we've understood very much is that unfortunately it takes too long to get to the right people when you do have severe asthma. And unfortunately people get exposed to significant amounts of oral corticosteroids, and we know they cause issues both in the short term and the long term. And certainly a lot of the studies that we've done suggest that even when we do start people on biologics, we can't necessarily reverse some of the damage, is not too strong a word to use, that has been done. So we really want to identify people as early as we can in their journey to put them on the right treatment first time. And certainly when we've looked in the past across the UK, people had disease, severe disease, for a median of about 4 or 5 years before they were referred to a severe asthma centre. And about 40 to 50% of people were already taking prednisolone every day before referral. And this is really the end product of a lot of work we've done. So we've had a specification around severe asthma services for a prolonged period of time, which I think has been very helpful in driving up standards. But this is really about identifying people with hidden severe asthma in primary care. You hear Steve talk to you about that. Deepak really around how we make sure that wherever you are in secondary or tertiary care, we all really work towards the same agenda, which is improving outcomes for people with asthma. And then David around some areas around tertiary care. And I think that's important. And one thing I would say is life is not all about biologics. And I was a fantastic meeting in Barcelona. It was a joy to be in a face-to-face meeting. But one of my colleagues from Denmark reminded me, biologics is the easy bit and is to some extent the most satisfying bit, because people come back and say, thank you, you've transformed my life. But actually, we all treat that whole person, and we all have fantastic MDTs. And we've clearly demonstrated that the whole systematic approach and the whole MDT approach improves outcomes beyond just the biologic intervention. So although we're focusing on biologics, we're really focusing on that whole person in front of us and making sure that whole MDT is involved. And if I would argue that the earlier that we're able to treat people with biologics or other interventions, then the less we need from the rest of our MDT, because we're preventing those long-term consequences from happening. So this is very important that we get this right and we speed up timelines. And having seen the slides already, I know David's going to show you some of the aspirations that we have. And that's my final point. This is a consensus, and this is the sort of second thing we've done as an asthma community. The first is Severe Asthma Toolkit, which again was fantastic and really helpful. This is a consensus. It's not tablets of stone, it's a guideline. If you feel really passionately, please do tell us. We've tried to push it out for very wide consultation. And what you see over the next 40 minutes or so will apply to your locality, but not in its entirety. I'm very cognizant of different populations, places, staff, and health inequalities. So this is one way of doing it, and you take those bits that you need to within that and adapt it for your locality to improve outcomes as quickly and as effectively as you can. I'm really pleased to be part of this, and I think it really has an opportunity for transformational change. So on that positive note, I'm going to hand over to Steve.
Andrew, thank you very much indeed. And Hitasha, yes, I agree. I think this has to be a pragmatic guide that we move forwards with. Could I move on to the next slide, please? I'm Steve Holmes. I do a variety of GP type roles, including work with the college and in the respiratory world. If you go on to the next slide, please. I've also got some academic and other conflicts or declarations of interest that you might be interested in. But I think the main thing, if we go on to the next slide, is that this is not supposed to be rocket science, but luckily none of us here, I hope, are rocket scientists. We are clinicians that want to provide good care. And although that slide that you see in front of you looks rather heavy, it is actually something you can look at, and I'm going to dissect it down in my parts before I hand over to Deepak. So if we move on to the next slide, please. The first thing from the point of view of asthma is remember that the vast majority of people with asthma are very well managed in primary care. There's an awful lot of people out there with asthma, as Andrew's already said. And if we can get good care, then we're helping the whole of the system. Some suggestions that come out from the AAC discussions have been having a local asthma champion, PCN level, integrated care system level, making sure there are leads that are helping to promote the good quality care of asthma. Also, good access to the investigations that will help us to make a good diagnosis. because whenever we're seeing people in primary care, it's really important we confirm we've got the diagnosis right. It's not always right when it's made in primary or secondary care in the past. So really just reevaluate again quickly. There are basics that we should get right across boundaries around inhaler technique and adherence. And when appropriate, we should be looking at further investigations and increasing up treatment as necessary, as well as addressing all those complex psychosocial issues, other medical comorbidities, and smoking. So we know it's not straightforward, especially when you're trying to do that in 15, 20 minutes, but it is something that we need to be providing good care for our patients. And also we need to be ticking boxes. So I deliberately put in, we also need to be assessing symptomatology and general lung function. That's normal asthma care. If we go on to the next slide, please. What we're going to be really concentrating on here is not the majority of our patients that are doing quite well, thank you very much, but those who have identified uncontrolled asthma. And for the purposes of the discussions, we came across frequent exacerbations. That's more than 2 in a year. Your average person in the UK, when I looked at some data published in the UK and America, suggested your average person with asthma would have an exacerbation every 10 to 12 years and be seen in an emergency department every 40 years. So someone going into hospital or going to the emergency department, that is not good asthma care. That's really indicating uncontrolled asthma. Similarly, if we think about poor symptom control, and one of the parameters around that is often not just poor symptom control, but increased use of a short-acting beta agonist, which we'll touch on in a moment. But if you look at the little box at the bottom, and these are explained in a little bit more detail in the interactive PDF you'll get access to, if someone's on maintenance oral corticosteroids for asthma, that really should be considered as a direct referral to a severe asthma centre so that that patient can be really carefully evaluated, hopefully removed from that oral corticosteroid and considered for things like the biological treatments. Let's go on to the next slide, please. It was interesting, we had quite a debate about how many courses of steroids should we go for. And I'm aware that I see a few patients who've died from asthma who may have had 10, 12 courses of oral corticosteroids. We went in the end for 2 or more, which is what the Primary Care Respiratory Society and the European Respiratory Society said. Remember, the National Review of Asthma Deaths was slightly more lenient, saying more than 2, i.e. 3 or plus, but we've gone for 2. Equally so, we didn't actually specify it had to be more than 12 short-acting beta agonists or 9 or 6. We know that all increased SABA use is potentially detrimental, is an indication of poor control, and leaves them more at risk. Get rid of the 12s first, then address the 9s, then move down to the 6th, and keep progressing from there. So that was part of one of the discussions we had developing this PDF. Go on to the next slide, please. Okay, so primary care, when is our chance to pick up these patients? Well, we've got the annual asthma review, which often has a QOF or often more complex template behind it, one of the Ardens type templates that allows us to assess control. And that probably is the mainstay. It probably hasn't been as easy to undertake that over the last couple of years, but we should be getting back to normal clinical practice soon and delivering on that. Second area where we think there's a good opportunity to catch all those high-risk patients is the person who's had an exacerbation. That little A&E letter that says, seen in A&E, treated for acute asthma, or the person being discharged from hospital. Now, in an ideal world, we'd expect those to be referred in for a specialist review, but if they're not, let's pick them up, get them assessed, and work out what's going on with them. And then perhaps the thing that hasn't been quite as widely advocated, but probably equally sensible, is that sort of proactive search to try to pick up those that might slip through the net. If I speak to many of my colleagues, they often tell me not all the patients with asthma want to come in for review. It can be really hard to get some people to come in. So we go on to the next slide, please. How can we pick up those people? Well, there's a variety of tools, one of which Spectra has been quite widely used. There's a prednisolone dashboard. There are several others. In fact, quite a lot of us can do some of these simple screening tools in our own clinical settings, either at a CCG or practice level. But again, it's about trying to detect those that are more at risk. And I'd promotes you Spectra, which has been quite widely used and tested if you're not using something or have the abilities to do that in your own unit. We've got more information about that. Go on to the next slide, please. When we're seeing that patient with poorly controlled asthma, there may be really simple basic things that we can do to improve their care. Inhaler technique, checking on adherence, good explanation, personalized asthma action plan to help with them, making sure that the problem actually is asthma and that we've confirmed that diagnosis, and then as appropriate, stepping up treatment and reviewing. So good standard clinical practice. Move on to the next slide, please. We do want to be thinking about potential other comorbidities. We do want to make sure that the patient has an inhaler they can use and is as green as possible. We should have had the green and the blue slightly changed around in the colors on that, but never mind. Having said that, we also want to make sure our patients aren't smoking and that their weight management is good, because weight management, smoking cessation, and the amount of exercise they're taking will often correlate quite well with the amount of breathlessness the patient has. Move on to the next slide, please. We've got a little tool again in this interactive PDF that probably helps just to highlight those that we might be thinking, okay, let's think about getting this person into specialist care. High intensity treatments. They're on high treatment already. They've had a severe exacerbation. I've checked their technique. I think that's okay. They're using their inhaler at the appropriate times, I believe. I can't think of anything else that's causing it. That's where we need to get additional help. And what we've done is sort of suggest that that should be within 6 months. Now, I can hear you gasp that because it's quite a long period of time. If you move on to the next slide, please. That was after quite a lot of discussion. And again, this would be seen as a maximum. This is where the patient hasn't been taking medication or they've been using their inhaler incorrectly. We've corrected that, reviewed it, possibly increased medication after that. But if we're still not winning, that needs to go on. So some patients might need the full 6 months. Many in primary care should be used and sent into more specialist care if we're not winning much earlier. Fine. Move on to the next slide, please. A couple of other things that need to be just highlighted before I hand over. Number one, an idea that we should be getting more integrated care across our healthcare communities, across the primary care networks, across the integrated care systems. There are a variety of models being developed for that. It's worthwhile thinking about what you're aiming to provide in your own locality, how much of that works with education, how much of that is at an individual practice level, and how much of that is part of an integrated team, and how that will relate to the individual practices. But plenty, again, to just stimulate a bit of thought of how can we use the expertise in specialist care and maximize the opportunity we've got in primary care. If we go on to the next slide, please. Finally, just before I hand over, when the diagnosis is made, what we're hoping is there'll be a clear identification. I did mention, like shotguns, when the person has a shotgun, we get a SNOMED code to add into the notes. I'm not suggesting severe asthma is like a shotgun, but having a SNOMED code to really identify these patients for further audits when it's necessary is one good key point. Number two is keep checking that inhaler technique just in case they're slipping through the net somewhere else in the system. And number three, like we do for some of the DMARDs and other hospital-only initiations, make sure you've added on the appropriate biologic that the patient is getting when they're under specialist care. But what we're going to do now is move into secondary care, and it's a great pleasure to welcome Deepak, my colleague from Derby, who will move us through that zone, hopefully in the next few minutes. Thanks, Deepak.
Fantastic. Thank you so much, Steve. That was a fantastic talk. Just a reminder, put your questions in the Q&A chat session as we go through. So I'm Deepak Subramanian. I'm one of the respiratory consultants at University Hospitals Derby and Burton. So we'll be talking through the secondary care part of the pathway. So in terms of the scope and aim of this section, really split it into 4 areas. One is to reduce the time from a secondary care referral to a comprehensive asthma assessment and initiation of either a biologic treatment trial or other appropriate treatment. 2 is to recognise and utilise the potential of secondary care centres to initiate and or monitor patients on asthma biologics. I think there's really a wealth of experience even outside of the severe asthma centres in terms of managing patients with severe asthma. I think it's really trying to unleash that potential of secondary care to take on a lot of this work. Thirdly, to set out the expectations of each secondary care centre. with respect to accepting referrals, assessment, objectives, and investigations. And then I'm going to give an overview of the service structure needed in centres and try and explain the rationale for the tier system. So on the left, we've got sort of how the wording is within the document, and it's still a bit of a work in progress. So if I start from the beginning in terms of an initiated referral from primary care, I guess what we're advocating is that initially there's a triage by a member of the respiratory or asthma team first. So when the referral comes in, it's reviewed. Investigations such as lung function, phenos, chest x-rays can be ordered prior to clinic visits, so that it's available to the practitioner at the time. It makes for a more effective clinic consultation, also reduces delay down the line. Now, some centres may have a one-stop shop clinic, and that's fine, but it's just to try and get some sight on those referrals, because some of them you may be able to look at them and identify that a patient may need a more urgent assessment. And that's certainly the way we run things locally. I'm aware that in Scotland, in Dundee, for example, they do an express vetting service, and that's quite effective in bringing people in. In terms of the timelines, we did debate whether we could shorten that 18-week referral, but I think there's a lot of complexities with that. So we've stuck with that sort of, from the point of referral, that 18-week national standard. Aware that referrals into a secondary care asthma clinic can come from many sources, community outreach team, secondary care, other secondary care clinics, paediatrics, post-hospital admissions, and ED. So it's really important that we've got robust pathways that lead into the clinic from those areas. So if I talk about sort of within the hospital, I think it's really important that we try to ensure that we establish sort of dedicated asthma clinics rather than patients being seen in general clinics by different consultants, different ST trainees, and that should really be applicable to all hospitals. And it's really about getting that right patient in the right clinic at the right time, and by doing so we can just rearrange existing services. I think the appropriate patients need to be seen in clinic post-hospital admission for an exacerbation, so mechanisms clearly need to be in place to identify these patients. There's lots of good examples from around the country. And the NACAP report identifies the elements of good practice on discharge, highlighting the key standards from BTS and the NICE quality standards. And important to have referral routes that links with paediatric teams for transition patients. So in terms of integrated care, as Steve has mentioned, and we've been talking about integrated care for years, and the real examples of it in practice are unfortunately a few. It's clearly part of the NHS long-term plan. BTS have talked about how it can enhance patient care back in 2007, and the position statement in 2019 highlighted that we can go from sort of a fragmented care to a more coordinated proactive care. I think if we get more involved in primary care, it can only be a good thing. Having more specialist support for patients with asthma in there allows for two-way discussions with shared decision-making and potentially identify patients to pull into a service. I'm relatively unique as an asthma clinician in that I work and part of my time in community and as well as the severe asthma service. So we run, as part of the Impact Plus service, about 10 virtual MVTs for our population of 600,000. That's 10 per month, mainly discussion patients with COPD and asthma. So when discussing patients with practice nurses, our respiratory nurses, we can really effectively manage them in the community, but also identify those that need to come into our service. I appreciate that's quite a hard step for a lot of areas, especially those that may not have a community respiratory team in place, but I think it's one to really think about for the future, and especially the potential to link in with community diagnostic centres in future. So that's why we've kept that in the pathway. In terms of roles and responsibilities, which is really applicable to all centres, we've said that any patient coming in with a pre-diagnosis of asthma should be assessed with the aim of objectively confirming or rejecting the diagnosis of asthma, ensuring appropriate asthma treatment in accordance with local and national guidance, assess adherence and address any problems, assess psychosocial factors, smoking, anxiety, look at housing, whether that's impacting on the patient's health, assess and treat relevant comorbidities, phenotyping patients according to biomarkers. We're talking about eosinophil counts, phenos, IgE, and assessing oral corticosteroid usage. In terms of the investigations that we think should be able to be performed by all secondary care centres, and this is pre-referral to a severe asthma centre or pre-discussion at a severe asthma MDT. So the list we've come up with is full lung function testing, including bronchodilator reversibility, measurement of exhaled nitric oxide, a eosinophil count, ideally a trend, and ideally to 2 decimal places, given recent biologics that we've got available, IgE with specifics to common air allergens, including fungi. HRCT scan, there was a bit of debate about that. I think it can be a useful tool in identifying patients with bronchiectasis, significant emphysema, so only if indicated, we need to go down that route. Adherence measures, review of prescription medications, collection rates of ICS containing inhalers, and review of SABA usage, and an assessment of relevant comorbidities. So in terms of the proposed service structure, we've again reiterated previous guidance that it's really imperative that each secondary care centre should have a nominated asthma lead. And that asthma lead should be really the point of contact that links in with the severe asthma centre. The change that we're proposing is that is this tier system. So where we would almost categorise each secondary care centre into either tier 1, tier 2, tier 3. And the allocation of a tier would be based by a discussion between the severe asthma centre and the secondary care centre. So it should be a collaborative decision. And it will be based on current experience, workforce, whether that be clinicians, specialist nurses, physio, speech and language therapists, specialist pharmacists, and dietitians. And the way it would work in practice would be that a primary care would just refer to its local centre, and it may be that it's a tier 1, tier 2, or tier 3, but they would just refer to the local. If it's tier 1, then those patients that may be suitable for discussion or review at the severe asthma centre would get referred and then get seen there and then worked up and managed from that point of view. Tier 2 would be a more interactive type discussion, and a tier 3's relationship with the severe asthma centre may be more virtual, so discussing patients at the severe asthma MDT, but we wouldn't expect patients to, or rarely need to go to that severe asthma physically. So I'll just highlight those tier 1s and tier 2s in a bit more detail. So tier 1 may be a centre that's unable to initiate biologics or hasn't done so currently, isn't probably monitoring biologics, referring all patients to the SAC, or maybe not engaging in the MDTs, and maybe because they've got a low asthma workforce. So the aim is to encourage those sites to have an asthma lead, support plans to develop asthma services, and try to ensure that referrals are in line with SAC asthma referral protocols. In terms of tier 2, that may be a centre which has got a designated asthma lead, engaging with the SAC network, experience of monitoring biologics, and our track record of high quality referrals. So the aim of those spokes is to, or that was a nomenclature before, to continue to engage in SACs and MDTs, accept patients back for monitoring after a treatment trial. And then a tier 3 would be a centre that maybe have a greater workforce, so a designated asthma lead with job plan time, possibly another consultant with an interest in asthma, a lead asthma nurse with dedicated time in severe asthma, biologics pharmacists, the ability to conduct MDTs with a multidisciplinary team. And the aim would be for them to, and probably centres that are initiating locally, monitoring biologics after approval at a SAC. So why do we end in tiers? We've all probably had enough of tiers with COVID, but from the consultation, the feedback was good, actually. I think people could recognise the value of it. Some suggested maybe we just have 2 tiers rather than 3. Some areas didn't like the hub and spoke nomenclature and preferred the tiers. I think it would help us map out the services and expertise across regions. We could help to identify gaps within care and identify inequalities of care. And I think knowing the tier 1 centres will be really important to help identify what support they need, whether that's through the severe asthma centre or through respiratory networks, but really important, maybe some deep dives to look at those areas and what input they need. Ideally, from my personal point of view, I'd like to see tier 3 have, or possibly even tier 2 have autonomy to prescribe biologics, but that's not the situation we're in now. But probably defining these areas almost enables us to see which centres are sort of have that sort of system readiness to be able to do that, and it may be able to give us more flexibility with commissioning models going forward. So thank you. I'll come to the end, and then I'm going to hand over to David Jackson to take over about the tertiary care. Thank you.
Thanks very much, Deepak. Hi, everyone. Good evening. My name is David Jackson. I lead the asthma service at Guy's and St Thomas's for that region. So I'm going to pick up where Deepak has left off and really talk about sort of the last part of the pathway, getting patients into the specialist centre and onto biologics. But first, I want to just mention where we are at the moment. Because fortunately, Hitasha and Lottie Renwick and others from Asthma UK looked at this over the last couple of years. And this is what the data looks like. So where available, you can see it's broken down into the different stages. And what you can see is that from when the patients were first referred to the centres and then until they were initiated on the biologics, this was over a year, 63 weeks. There was on average 13 weeks between referral to the centre and being seen, 38 weeks, more than 6 months between when they were first seen and being approved by the MDT, and then actually not too bad as an average 6 weeks getting onto the biologic. What the data also showed was that there's significant variability. And this is really one of the key things we're trying to minimize in this whole process. And you can see that here. So what we're looking at here is the time between MDT approval for the biologic. So the patient's gone through, been seen by the specialist center, MDT's approved the biologic. All that's required now is for them to be given the first dose. And the dark blue here reflects what was happening in 2019, before the pandemic started. Slightly lighter blue is 2020, and then you've got the overall average. You can see that in 2019, about a third of patients were getting the biologic within 4 weeks, approximately up to 4 weeks of the MDT. And this increased to about 40, just over 40% in 2020. So things are already starting to move, but you can see also that there's about 60% of patients then who are on this sort of right tail here, many of whom are waiting a long time. So just before the pandemic started, we did a Delphi study to really understand what the asthma community in the UK thinks is an appropriate time interval for patients to wait, from referral, from when they should be seen in clinic, discuss the MDT and so on. And we took the views of over 100 people in total. This was a mixture of different healthcare professionals working in the asthma service and also a group, fortunately, of 15 patients. And I'm not going to go through all the findings because of time, but there are a few recommendations of the total that really contributed to what I'm going to show you in a moment. The first, which achieved 86% consensus from the 100 and whatever number of subjects there were that every patient with a suspected severe asthma should be seen within 8 weeks of referral. The second, that MDTs should occur at least monthly, and therefore no patient who is referred to the MDT should wait more than a month. And thirdly, that once approved by the severe asthma MDT, for biologic therapy, that initiation shouldn't be delayed because of non-clinical reasons by more than 4 weeks. And so this then feeds into the pathway in orange here. And so you can see the going from secondary care to severe asthma center, there's the 8-week interval that we're aiming for, 4 weeks from severe asthma center to the MDT where appropriate, and 4 weeks from MDT approval for the biologic to initiation. So in some patients, and I'm going to stress some, because this isn't appropriate for everybody, there will be some patients who have other significant comorbidities that need managing, there'll be other issues that are going on. But there is the potential, at least, for some patients with very sort of straightforward textbook severe asthma, for lack of a better word, that they actually can get from referral to starting a biologic in no more than 16 weeks. And by the way, 16 weeks, if you think about a patient who is on 10 milligrams a day of prednisolone, staying on that 10 milligram dose from referral until that biologic is already more than a gram of prednisolone, which very good data now shows doubles your risk of osteoporosis, massively increases your risk of many, many comorbidities. So we're really trying to minimize this time as much as possible for good reason. This is the overview, and I'm going to just briefly go through the content of some of these boxes. The first box relates to the MDT meeting with spoke sites. As I've mentioned, the goal here is to offer a minimum of monthly virtual MDT meetings to spoke centres. Where there are more concerning patients, urgent cases, there should be opportunity to discuss them at least every 2 weeks. And it is important that the Severe Asthma Centre creates that opportunity for these spoke centres. Clinicians should be able to discuss new or existing patients and utilise the MDT expertise. The idea is that it streamlines the subsequent review at the Severe Asthma Centre, because within that discussion, it becomes clear actually which members of the MDT that patient should see. Is it speech and language therapist? If there is a suspicion of laryngeal involvement, dysfunction, is it breathing pattern disorder, whether physiotherapists need to be involved? Is it a clinical psychologist? The next box relates to biologic approval and initiation. Obviously, the approval will follow NICE criteria. As I've mentioned, the goal is that it should be initiated within 4 weeks of MDT approval. Patients should be encouraged to use the My Asthma Biologic app, which will be coming out, and hopefully this will really support the patient and support data entry into the UK Severe Asthma Registry, which is important for us to continue to learn and understand what goes on and advance our understanding of asthma generally. And finally, that it's important that patients should be offered home administration as soon as is clinically and practically possible, and certainly within 6 months. But this should obviously, follow what is appropriate for the patient. And there are some centres in the UK that offer this immediately, where the first dose is at home, others where it starts from the second or third. There is no right and wrong, but it must be in the best interest of the patient. The next box relates to monitoring of patients on biologics. And really, we've broken this down into the first year. And again, this is a guide. Patients not on maintenance prednisolone, in the first year, it's reasonable to review them every 3 to 6 months, depending on how they're getting on. When they're on maintenance prednisolone, it's better to see them more frequently. This guides a more efficient steroid wean. It allows you to understand if there are factors contributing to why it's been difficult to wean the steroids. And obviously, it's important to assess adrenal function, as certainly you're getting down towards and below 5 milligrams of prednisolone a day. Patients should be assessed for response, and this should happen really at 6 months, the first main time point. Indicators of suboptimal response can include a failure to sort of really see a significant improvement in symptoms, day-to-day symptoms, a failure to significantly reduce maintenance prednisolone dose, and we've given a guide here of a failure to reduce by at least 50%. Bearing in mind that the phase 3 studies, the steroid-sparing studies of mepolizumab with Sirius or benralizumab and Zondo or Venture with dupilumab, many of these patients were able to completely stop by 6 months. So it's reasonable to say that at least 50% by 6 months. And obviously no significant reduction in exacerbation frequency, which is one of the key outcome measures that most of these patients are started on biologics for. There's different ways to assess suboptimal response, and it will differ from patient to patient, but medication adherence is very, very important. Guarino d'Ancona has published some very important work highlighting the fact that some patients who continue to exacerbate despite biologics do this because they've become less adherent to inhaled steroids. In terms of the interactions between the spokes and asthma centres, again, we've sort of laid out a few points as a guide for the kind of situations in which it's important for the spoke to discuss at the MDT of the Severe Asthma Centre, so that those complex cases can be looked into in greater detail. Again, this really links to those patients who have had a suboptimal response as defined by failure to come off prednisolone and so on, as you can see here. We've also offered a guide for weaning off steroids. And this is taken from the Ponente study, which was a benralizumab study. And it will be arguably slightly different for other biologics, but I think in essence, it shouldn't be particularly different from biologic to biologic. The only real difference relates to when you may start weaning. With a drug that's very fast acting, like benralizumab or dupilumab, it can happen very quickly after the first dose, with slightly slower onset of action. Some of the other biologics, perhaps you wait until the second dose. Again, it's not particularly evidence-based in terms of when you start weaning. What we do know is that the pathway shown here that was used in Ponente is safe and was very effective in this study. In terms of a longer-term follow-up, it's reasonable for most patients to touch base at least 6 monthly with the patients. This can be virtual, it can be face-to-face. It doesn't have to be specifically done by a doctor, but the asthma nurse specialist, the asthma pharmacist can do it, all really depending on what the scenario of the patient is. It's important, though, I think, for the patient to be seen face-to-face if they are experiencing, 2 or more exacerbations, more than a single exacerbation, despite the biologic, because these are patients who really need to understand what is going on. Is it that they have now developed chronic airway infection, and these are bacterial events? Is it because they've developed antibodies to the drug? Do they need to switch to a different biologic, and so on? We've also put guidance in relating to what happens after the first year of treatment. There are patients, and probably a number about 50% of some of the better biologics who achieve this super responder status, who, for all intents and purposes, feel like their asthma is in remission. And for these patients who no longer require any prednisolone for their asthma, whether it be for an exacerbation or as a maintenance dose, and have very low symptom scores, it's perfectly reasonable to repatriate these patients back to the spoke hospitals. And on that note, I'm going to stop. Happy to take any questions after Hitasha finishes off.
Thanks, David, and thanks, Deepak and Steve as well. So really, I'm hoping that over the last sort of 30 minutes, we've sort of presented this consensus pathway, and I'm hoping that it provides a clear guide of when to refer to secondary care or severe asthma centres. It provides a bit more clarity on the roles and responsibilities each stage of the pathway, and I think we had a big ask that that's what was required. We've tried to put in some guidance on timeframes. I think it's really important for the patient, because we know that sometimes it can take a really, really long time, and we've all met those patients say we waited years to get here, and really I think we need to shorten those years to a much shorter time frame. And also I'm hoping that you see it as a pragmatic guide, and we can try and sort of reduce the variation that we have nationally. So if there is a guide that we can refer to, hopefully as people start to adopt it, we can bring down the variation in care that we see across the country. Hannah, could you go to the next slide, please? So where can you find more information? So the Oxford AHSN website has the biologics toolkit. And I know some of you have asked about where the severe asthma centres are. There's a map on the toolkit. There's loads more resources in that toolkit. There are links to our other modules that we produced. There's some educational modules. There's previous webinars. There's podcasts that can sort of help patients, help clinicians in their management of patients with uncontrolled asthma and severe asthma. There's a link to one of the search tools we've developed, but please, I know people have other tools to use. As long as we're being proactive in finding these patients and then moving them forward in the pathway, that's the most important thing. And so the next slide, and also the interactive PDF will go onto the Oxford AHSN website, so do go there to find it at the end of April. And really now it leaves me with the panel discussion. So the next slide, please, Hannah. If I can get all the panelists to just put their camera back on, that's great. And I might start off with the first question, and that's to David, and that's really about definitions. So we hear lots of words about sort of severe asthma, difficult to control asthma, uncontrolled asthma. What are your thoughts on these definitions, and how can we help people sort of